This program is a presentation of UCTV for educational and non-commercial use only.
My name is David Young, and I have been practicing plastic surgery here at UCSF since I finished my residency in 1992. To me, it doesn't seem that long ago, but I think it's been quite a while when I tell that to the medical students. So in all of that time that I've been here, my major interest in treating patients as well as in research has been in how wounds heal. From the very simple to the more complex. And what I'm hoping to do this evening is to try to distill a lot of information. Obviously, all of these classes are distilling a lot of information into a few take-home messages so that you can get a flavor of what wound healing is all about in terms of clinical practice, as well as what the future holds for patients with wounds that don't heal. We don't have the answer to everything. That's what's so exciting about the science. But we have learned a lot in the last 20 years in how to treat these problem wounds. So let's get started. The first thing that I'm required to do is let you know that I have a financial disclosure. I work as a consultant on a very part-time basis for Smith & Nephew, which is a company that makes a product that I'll be talking about. My only defense is that I'm going to tell you why it shouldn't be used, as opposed to try to convince you to use it. So I may be paid by them as a consultant, but my take-home message will be that product is overused and should be used on only a limited basis. So I'm hoping that gives you the idea that it shouldn't, my being paid should not prejudice the opinion. So just as an overview of what I'd like to cover, are these specific topics. Some are very brief and some are quite elaborate. But I'd like to go over how wounds heal. That's sort of what we know from hundreds of years of observing, thousands of years really, of observing how people and organisms heal their wounds, and then give you some rationale about why we treat wounds. Not all wounds need to be treated, and why do we treat some wounds and not others, what treatments are currently available, and then go on to when wounds become problems. So when is it that as a plastic surgeon or as physicians in general, we should be involved in these wounds. And then finally, depending on how much time there is, I'll cover a few of the hot topics in research that are going on in wound healing. As with all of these topics, the first thing is to sort of get you up to speed on the anatomy and the physiology of the issue at hand. So as plastic surgeons, we love to say we study the biggest organ in the body, and that's the skin. The skin is, in terms of wound healing, has really one major purpose, and that is to separate you from your environment. And all organisms need that. From paramecium to mammals, if you can't separate your innards from your outers, then things go wrong. And just simply put, this whole talk is going to be about how we establish barriers, what's the purpose of the barriers, and how do we reestablish the barriers. When you look at the skin under a microscope, this is a diagram, or a line drawing really, of the skin. It's very thin. It's no thicker than a thin piece of cardboard or a standard piece of cardboard. And I put the measurements, standard measurements next to the drawing. Here's a picture of real skin under the microscope. When you look, it's not that much different from the line drawing. I'm going to start to use the pointer now. Here's a hair follicle. Here's a gland that secretes oil. These blue areas are cells, and that's the living part of the skin. The skin is, as I said, that cardboard paper thick piece of tissue, but all of the barrier function is actually right here in that very thin layer. So that when you have heat, when you have radiation, bacteria, all of those things are protected from the inside to the outside by that very thin layer. And this is called the epidermis. And it serves as the barrier layer. The rest of the skin is called the dermis, and its purpose is actually to allow you to flex and move, the viscoelastic properties of skin. And I know this is really cheesy, but I have a little, the little motion of the skin, just demonstrating that the dermis allows you to stretch and contract. Without it, you would literally be encased in a ball of cement. And there are actually patients who have lost that dermis and are only covered by epidermis, and they really literally cannot move. So we know that the dermis is very important for this. But for today, I'm going to largely talk about the epidermis, because that's the functional part of the skin in wound healing that separates you from your environment. This photo is, and by the way, I'm sure that there, in all of these talks, there are gross photos, or they're not. And so I don't have many pretty pictures. They're all wounds are not very pretty. But this illustration is a dramatic illustration of actually how good human beings or animals are at healing their wounds. As a matter of fact, one of the toughest things in doing research about wound healing is to stop the wound from healing. If you think about it in terms of evolution, that you have to be pretty good at healing a wound. Because if an organism weren't good at healing that injury, you would have died a long time ago, or you would have stopped. You would have been an evolutionary dead end. And there are instances where we find animals and humans that have wound healing problems, and I'll talk about those. But those are very actually rare. If you think about how often you cut yourself, you fall and you scrape your knee, et cetera, you don't have to actually do much, and the wound will heal. So it's an automatic mechanism programmed by nature to carry on healing. And we have to actually go to great lengths in the laboratory to stop that healing, so we can examine what are the factors that go into making the wound heal normally and abnormally. So this gentleman, he's a 40-some-year-old farmer who came to UCSF Medical Center because he ran his ATV, those three-wheel vehicles, into the back of a truck. So the truck basically hit him on the forehead. So he went under the truck. And he came with this scar across his forehead. And then when you, for simplicity, I didn't show this CT scan, but basically he came with a fracture of the skull in this area, sort of multiple pieces. And along with the neurosurgeon, we had to go in and fix that fracture. And in order to do so, it would seem like you could just make that open that wound up and fix the fracture. However, because of a lot of anatomic structures that I won't go into specifically, we actually had to make a cut on the top of his head in order to access that area. So he had 2 scars now. He had a scar on his forehead, and then he had another open area on the top of his head. And you can tell he's bald. So you sort of say, well, this is horrible. He's going to look terrible. And here is the scalp completely peeled back. And these are the fracture fragments that we found. And then we removed some of those fragments, and the brain is underneath here. And so the neurosurgeon did what they needed to do. And then when he was all finished, we put the pieces back into place. This was actually took quite some time because it was like a puzzle. You had to sort of figure out where all the little pieces are. And we actually labeled each of the pieces with numbers. And then put him back together again. And he's healed quite well. This is without doing anything other than putting some sutures in. And he healed his scalp quite well. And this is actually what usually happens. It's a dramatic case of it, but this is typically what happens when wounds heal correctly. And as I said, who knows, 99.999% of all wounds heal correctly. We only see the people who have problems. But just because the wound heals properly doesn't mean that it's invisible. There are situations that we see where the wound heals well, but they cause the patient some distress. And largely, we think of that as cosmetic, but it's cosmetic only in a sense of it's a look. It won't kill you if you have a scar like that on your thigh, but it's not normal. So clearly, people are not born with these things on their thigh. This is due to a scald burn from hot water, and it eventually healed. But this is a visible scar. And then there are other visible scars. This is a teenager who had to undergo brain surgery, and you could see that with his hair cut in such a way, it's quite visible. And then there are other scars like this, where this child had a seizure and fell into a table and went to the emergency room, and the wound was closed, but ended up with this quite visible scar. Again, he will survive. He's not going to get an infection. He's not going to have physical problems with this, but clearly this is not what you would want to see happen, and this is a large part of what we deal with in terms of healing scars or healing wounds to try to minimize these problems. And here's a young girl with, again, in a motor vehicle accident and had cuts on the back of her neck that were treated and ended up with these visible scars. So with that sort of introduction of healing and scars, I just want to go into how it is that wounds heal. It's basically what we understand in 2010, how these wounds heal on a regular basis. So as everyone knows from your own common experience, when you get a cut, you bleed. And when you bleed, if all goes well, you clot. And when you clot, we've been able to, or many people have shown that this clot fills up with a lot of different things, proteins, cells, primarily platelets. Platelets cause blood to clot, red blood cells, and then a whole host of cells come in from the blood system, from the bleeding, to start a very coordinated effort of healing that, again, like I said, is hard to stop. Once it starts, it's very hard to stop. Nature has programmed this to happen on a regular basis. Now, what is this diagram was drawn probably around the year 2002 from the bibliography. What we have found since then is that a lot of these cells are stem cells. They're cells that actually come from the bone marrow and come to this area. And the reason why I mention it here is because at the end of the talk, I'll bring up that subject in terms of what we know about stem cells and wound healing and give you a flavor of what the future holds. At any rate, so this happens in the first 2 hours after the injury. And then over time, the cells migrate into this area. Remember I talked about the epidermis. That's the critical layer that has to reestablish itself before you can protect yourself from the environment. And these cells start to multiply and creep across this clot. And they literally creep across to the point where this clot then falls off. And everyone, again, has experienced that layer over the wound that develops a little crust and then falls off. So that's the dry clot falling off after these cells have bridge that gap again. And then all of these cells in here are busy making the tissue that would reestablish that dermis that I spoke about, that elastic property of the dermis. And they typically well, it's been shown to be fibroblasts that make, excuse me, that make collagen. And again, these stem cells do a lot. And there are multiple cells that go in and make blood vessels to reestablish the perfusion to that tissue. Eventually, the epithelial bridge spans the whole gap, and you get healing. Now, this diagram is really not completely accurate, because here you don't see the evidence of the wound that was there. In truth, the diagram should show something like this, that when all is done and all goes well, you have a little scar here, which is largely collagen. And that's when all goes well. And you have a very thin line, and it's not visible from above very much. Now, if all does not go completely well, you'll get and probably if you look over your own body, you'll find a few places that's happened. The scar will be a little bit raised, and that's when it's a noticeable scar. And the reason why you notice it, you can feel it, but the reason why you can see it is because it's irregular. It's not smooth to the skin. And when you're in light, the light will cast a shadow on that area, and that becomes a noticeable scar. So the little diagram here is to show that that little shadow that you see is what brings your eye to notice that scar. And this is typically something that from a child, again, hitting a table, a pretty good result, but you can still see the scar. It's a little overexposed, but I challenge you all you can still see it. It bothers the child, and it bothers the parents that has occurred. Now, hypertrophic scars, this is a little definition for you, that patients frequently ask me. A hypertrophic scar is a scar that still stays within the boundary of the injury, but now is quite raised. So here's the original diagram of the visible scar. Now you have a scar that is bigger and taller. Not really big, not really tall, but a little bit bigger and a little bit taller. And frequently, and so the shadow that it casts is much larger and much more visible. And frequently it's a different color. It's a little redder than the typical scar. And this would be an example of a hypertrophic scar where this patient had been burned and had to, we took the burn away, but then we closed the skin, but because of the injury he developed more excessive healing than we would have liked to see, and you can see these raised areas that are the hallmarks of a hypertrophic scar.
Could you go back to the normal scar? Hypertrophic. Yeah, that's the picture.
Yes.
Sorry. The boy. So
I was trying to look for a more. So it's either I have scars that are really visible or really invisible. This is the one that I sort of settled on as being partially visible. You can. It's. I'm tracing it here on it with a. It's right there. Okay. But again, you can look at your own body. I mean, I can find one on myself. That you can actually, you notice it, you can see it, it's there. And that's, again, a regular scar. It's not a hypertrophic scar, it's a regular scar, but it tends to be more visible, as opposed to the other scar that I showed you from the other gentleman, which is less visible. Now, a lot of that is a trick of the eye, because, and a trick of the eye in what plastic surgeons do, one of the things we learn to do is to make the scar blend in with a wrinkle. So, and if you'll notice, most of the scars that I'm showing that are visible are in younger people, and most of the good results I'm showing are in older people. So the more wrinkles that you have, the easier it is to hide the scar within a wrinkle. But again, in the illustration why I pointed it out is because there's never going to be a wrinkle that goes in that direction on that kid. So it's part of the geometry of how he injured himself and how it was repaired that it is more visible. And so it's both the scar itself as well as its orientation that leads your eye to look at that more. But getting to hypertrophic scars, so this is and please feel free to ask questions. Thank you for asking questions. I will, if we don't get the end of the talk, I won't feel insulted. So we can I prefer to just answer questions going along. Now, the next thing is, what are keloids? People frequently ask what keloids are. And biologically, it's hard to define we can't, there's no signature of a keloid. We can't do a test for it. The keloids and hypertrophic scars are a blend. They tend to be sometimes indistinguishable from one another. But one of the things that we use as a definition of what the difference is between a hypertrophic scar and a keloid is that a hypertrophic scar will stay within the injury itself, while a keloid will massively overgrow whatever original injury it was that caused the scar to begin with. And the example of that, the most common example is that of an ear piercing. So here's my little diagram showing. So when the scar goes way beyond the expected area of scarring, we will call that a keloid. And so this is a little ear piercing, right? So, I mean, this is far greater of a scar than you would expect from just a little hole through the ear. And this is an extreme example of a keloid from an injury to the ear. And I can show you dozens of photographs of other parts of the body, but the ear is sort of the most dramatic area for these. And so, so for or my use of the definition, or how plastic surgeons define it, is the keloid is really a rare item. Hypertrophic scars are fairly common, and the keloid is something that it's almost like it's not a malignancy, but it's kind of like a malignancy where it spreads. It spreads beyond where you would expect it to go. And then finally, there are wide scars. Scars that were wide to begin with and have stayed wide. And that typically is an example. So for instance, here there's a gentleman who had a bad infection. This is, just to orient you, his head is up here, his feet are down here, and this is his thigh and abdominal area. He had a necrotizing infection that required extensive areas of debridement to remove all of the necrotic tissue. And then once you do that, once you get rid of the dead tissue, the bacteria is gone, and now the body starts to heal. And this pink tissue is healthy granulation tissue, and that's what we want to see. Now, if you were to just leave this open and allow it to heal by itself, it would take months, if not years, for that to heal. And so the trick that we use is to take skin from other parts of the body, transfer it over to that part, and let the skin heal in. This is called a skin graft, and I'll go over that a little bit later also. And then fairly quickly he recovers, and the barrier is restored. But you can see that it's not normal. It's not what you would see before the injury. And this area is quite thin. There's a lot of loss of the underlying tissue, and it's quite visible. So that's an example of a wide scar that is very visible. So moving on. So that's a sort of a primer on wound healing, basically. And so why do we treat the wounds? I think an obvious and simple answer is that if you don't treat the wound, it will cause certain problems that we know happen on a regular basis. A wound left open too long will get contaminated with bacteria. You no longer have that protection against bacteria. Bacteria, despite all of our best efforts to keep bacteria from growing, you have bacteria on your body. You cannot eliminate that. You may bathe, you may scrub, but fairly quickly the bacteria will grow back. And it's just part of sort of our symbiotic existence with nature that there are no organisms, or there are no humans where there is absolutely no bacteria on their body, except in very rare circumstances. So if you have a piece of dead tissue on your body, that bacteria will grow there and cause an infection. If you remove the dead tissue, like I showed you on that gentleman, it gives the body a fighting chance to keep the bacteria at bay. Not forever, but long enough to get to the point of healing and survival. So the one thing that kills a lot of people when they have these large wounds that won't heal is obviously infection. The infection gets into the blood, eventually travels to the rest of the body, and death ensues. And that's why everyone knows that if you have gangrene of your foot or your leg, that it needs to be cut off. Because if you keep that gangrene there, eventually, either quickly or slowly, you'll end up with an infection that's not treatable and you'll die from that. So we remove the dead tissue to prevent infection. We restore the barrier. Once you restore the barrier, the bacteria can't get in, but also the barrier keeps your bodily fluids from leaving. So there's a lot of proteins, a lot of fluid within your body, and on these large wounds, such as burn patients, they lose a lot of fluid through those wounds. They lose a lot of protein. And once you restore the barrier, you stop that leakage of your bodily fluids outward and help the patient survive. And finally, I'm hoping to convince you that reducing the scar is not a trivial and silly thing to do. And finally, because of healthcare reform, healing the wound actually reduces the expense of the wound. That the expense in terms of loss of productivity of the patient, as well as just all of the paraphernalia that you have to use in order to keep the wound clean and healing. And what treatments are available? The simplest is what we call, so I'm going to go through a ladder of things that we do from the simplest to the more complicated. There's obviously overlaps in some of these treatments. Excuse me. The simplest is primary closure. That's the gentleman that I showed you before. And this is another gentleman, actually a friend of mine who was visiting in town, who fell and hit his face on a coffee table. And there's a gash here through the forehead. Plastic surgeons spend a lot of their evenings going to the emergency room to sew up people who fall. So here's a gash on his forehead and a gash on his nose and a gash on his lip. And if you do it correctly, you can, again, clean these wounds out, close them in such a way that they sort of blend in with a skin wrinkle. And he sent me this photograph a little while later, saying that I'd done a great job and thank you very much. But again, it's a trick of the eye because first of all, the photograph's a little fuzzy, but most of it is because he already had wrinkles to begin with. And so those scars that would have been much more noticeable in someone younger is less noticeable because of the aging of the skin. The second is called secondary intention. And actually, this is probably the simplest. It's a little bit out of order. Primary closure requires a little surgery. It requires a little effort on the part of the patient to undergo that. But if you actually just left the wound alone, it will close by itself. As I said, nature has made a very good system of wound closure. And if you just left it to itself, leaving it open, it will eventually close. And that's called secondary intention. Here's an example of a patient with just a pressure ulcer on their toe, with a necrotic area over it. And just by putting salves on it, not special salves, but just very common salves, the body will eventually rid itself of this little scab and then heal 4 months later. So if you did nothing but wash the wound and keep it bandaged, it will eventually heal. Now, in someone who is, say, 12 years old, this will probably take 2 weeks. But in someone who's a little bit older, as this patient was, it may take up to 4 months for it to heal. So I don't want you to take the message away that this is a really long time, but it can be a long time, but it eventually will work.
Question.
Yes?
On a really practical level, it's always a question to me. Do you keep it banded? How long do you keep it banded? And how long do you let the air get?
Yes, so I'll try to touch upon that a little bit later in terms of the treatment options we have for open wounds. Actually, I'm coming right to that area right here. But no. But I wanted to answer the question in a global way, and that is to say that different people have different styles of doing it. There's certain things that we know to be based upon scientific principle, but a lot of medicine and a lot of wound healing is what your grandmother sort of taught you. And so a lot of these things don't have necessarily a scientific proof of principle. Except to say that what we know is whatever you do to keep the bacterial count down and whatever you do to keep the environment hospitable for cell growth, those are the things that have been shown to minimize problems and to maximize healing. Now, there are times when actually opening the wound to air might achieve that, and other times when keeping it covered will achieve that same thing. So it depends on the situation. But I'd say when in doubt, it's better to cover the wound than it is to leave it open, as a general rule. So this gentleman had a pressure ulcer of the heel, and you can see that now this is quite a bit larger than the other wound, and to treat that with salves and allow it to heal by itself would take far more than 4 months. So for this gentleman, we deemed it more necessary to actually remove that dead tissue surgically and then perform other surgeries in order to get that wound to heal. But again, we could have just put a dressing on it and allowed it to heal by itself, but it would have taken much longer than 4 months. Debridement. So I just want to go into sort of how do we treat wounds in a, say, standard fashion, so that we're not, it's not rushing you to the operating room. It's not doing all these fancy operations. Wounds will heal. Again, the wounds that we have problems with will heal with most of them will heal with just a little help. They don't require all this intensive surgical intervention. The vast majority of these wounds that have some debris on them, they will respond to chemicals that will allow the body to soften the dead tissue naturally and have them fall off. Unfortunately, the only product left on the market, there were more products a few years ago, but they all got pulled for some reason due to FDA concerns. The best product that I like to use was actually made from papaya paste. I don't know if any cooks in the room. So meat softener, the meat tenderizer is made from papain, exactly, from papaya. And the best product that I was using was a chemical that was made from, that had papain in it. And you could put that onto the wound, and just like it would tenderize your beef stew, it would tenderize the wound. And then when you got in the shower and washed, it would wash this all off. Excuse me. That got pulled because of a lot of people had hypersensitivity reactions to it. And the other product that works similar but is probably a little less potent is collagenase. And that's an enzyme that will dissolve the collagen. So a lot of this debris here is dead collagen. If you put the collagenase on, it'll soften it up. And I want to emphasize that the chemical helps probably 10%. The body is already doing 90% of the work in softening this stuff up. There are surgical methods that are things that we can use in the clinic. There's the age-old steel. So there's surgical steel. But now in this day and age, there are more modern ways and better ways of doing it. The machine that I like to use is called a VersaJet. It's actually a spray of water. It's a very intense. It's far more strong than like the what do they call for cleaning your teeth? The water pick or whatever those things are. ultrasonic scalers. This will actually cause you to bleed. This will cut through the tissue. But the jet is very, very fine, and it will just take off a little small layer at a time. And then this is just a product that I use. There are many other products on the market for that same purpose. I want to touch upon moist environment. What has been shown in fairly good clinical studies is that a fluid-filled environment is better than a dry environment. And I won't go through all of the literature on it, but it's pretty well accepted that if you keep a wound moist, it sort of makes sense. The cells want to be in moisture. They don't really do that well on a desktop or whatever. They like to stay within where there's bodily fluids, the correct bodily fluids. And so all of the products, the majority of products out in the market now that are successful promote that moist environment. Moist environment with low bacteria. So there's a balance. Moist environments promote healing of wounds by allowing the cells to grow, but they also allow bacteria to grow. So it's a balance of keeping the bacterial count down and allowing the body's own cells to grow. And so these are just examples of various products that will do that. I don't endorse any of them. No one pays me for these things, and they by and large all work fairly similarly. Excuse me. So the moist environment, though, has to be, as I said, coupled with antibacterial activities. And probably the oldest product on the market from the 50s is actually called Silvadene. It was originally made to treat burn patients, and as with all these products, when they first come out, they're super expensive. It can be only used on the sickest person. But now Silvadene you could buy it, in buckets for a few dollars. However, it's been superseded by other products that are more expensive, and some of them probably don't work any better, but some actually do work better. Their common denominator is that they all contain some form of silver. It's kind of odd. It's actually not that well understood, but silver appears to delay the growth of bacteria or to actually kill bacteria. So all of these products have some link or another to silver, and that's something that I don't pretend to understand exactly why that is. And I actually don't think the companies themselves actually understand too well, although you'll have brochures filled with why silver is good for you. Then there are biologic dressings, those things which have some kind of material in them that is from animal tissue or humans. So this is a skin graft, but it's not from the patients themselves. I showed that other patient that had their own skin graft. This skin graft was actually from a cadaver, so you can take skin that has been donated and you can put that onto a wound. It won't stay there permanently, but it will help promote the healing process. And this is an old product called BioBrain. BioBrain is a plastic material with collagen on the inside, so you can actually, it will stick to second-degree burns, as this patient has, and will help promote healing in those situations. And then moving on to the next more complicated form of intervention is that's a skin graft. And here's an example of a patient that I did a skin graft on. This is a skin cancer that required to be removed. And once it's removed, you can see that the skin is gone, obviously, from around the cancer, and all of the muscles underlying it are exposed. And you take some skin from another part of the body and you actually put it there. So the question I always get is, well, so what happens to the area where you take the skin from, right? So right, you steal from Peter to pay Paul. So how do you get away with that? In certain situations, in small areas, you can take a full thickness piece of skin, let's say in the groin, and you can actually just close it because you have extra skin there. And the older you are, the more extra skin that you have. So you can actually steal skin from places and just take those areas and just close them. But for the vast majority of patients that need these large areas, you need large pieces of skin. And the reason why you can do this is you're only taking a partial thickness of the skin. So these are called split thickness skin grafts. And those cells that I told you about that start to grow, they're in hair follicles. They reside in sweat glands and hair follicles. And so if you're careful and you remove the piece of skin leaving behind the deeper structures that have the hair follicles in them, those cells will start to proliferate. They'll migrate out and heal, restore that barrier. And if you think about it, over your body, the hair follicles are not that far apart from each other. They're fairly close. So the cells have to grow out, and all they have to grow is halfway to the next hair follicle. So each hair follicle has to produce enough cells so that it grows out radially to fill that gap between hair follicles. Now, the area that you take that skin from isn't normal anymore. You've taken some areas of it off, but it restores itself enough so that the barrier is restored. And so you're safe at that point. We don't take skin grafts willy-nilly. There is some cost to it, but not so much that it's not worth healing those other areas in order to steal from those first areas. And so it's well known that if you take skin from the thigh or the buttock or whatever, the hair follicles are close enough together that on the average human being, 7 to 10 days later, that barrier is restored. If you take it from the scalp, which sometimes we have to do, where the hair follicles are even more robust and closer together, that healing can be even quicker. But typically, it takes about 7 to 10 days for those donor sites where you're taking those skin grafts to heal on their own. Now, so you end up with this is a different patient, obviously, than that first patient, but this is a typical healed product of how the skin graft looks once it's all healed in. And this patient didn't like it. And so at this point, after the wound is healed, after the tissue has softened up, then we can do a second operation where we come in and actually just pull the edges. So now people tend to gain a little weight, et cetera, et cetera. So over time, this area will soften up. So a large piece of skin graft like that, which originally had to be put there because we couldn't get the skin to stretch, later on we can get lucky at times and actually pull those edges together and cut away that old skin graft, allowing the wound to now heal in a straight line, thus converting that wide scar to a narrow scar that is much easier to hide. So that's a trick that we use for most of these unsightly scars, is if we can pinch the skin together and eliminate the scar, we take out the scar and pinch it together. Now, there are even other more sophisticated methods where we put balloons under the skin. And I don't have examples to show you of that here, but you can actually bury balloons around this area, blow the balloons up so it stretches the normal skin, and then use those to close. So those are all techniques that we can use to eventually close this wound and get the scar away. But the first priority is actually to get the skin to heal so that you don't have infection at that point. Yes, absolutely.
I'm still wondering about the skin graft. How do you take such a small section of the donor skin? How do you separate that?
Well, originally when it was done, when it became popular back in the 30s, 40s, and 50s, the surgeons were quite proud that they can actually do it with a scalpel, that they can actually take a very sharp knife and just, they were special scalpels. They were just sort of large razor blades that they could do this. And I actually, during my training, had met some of these people that could do this, but it's a lost art. Now there's a machine that will do it. The machine actually is quite good at measuring the depth of the skin. So it's much like a razor, like a straight razor, but with a safety guard on it, so that it only allows you that razor to cut at a certain depth, and then that razor is driven by a motor that goes back and forth real quickly, so that the guard allows only a certain amount of the skin, and the razor goes back, oscillates back and forth, cutting the skin. Can you picture that, or it's basically just a fancy device for cutting them. But you can take a sharp knife and just do that. But it's really hard because you get too thin and it perforates it. You get too thick and you end up too far down. So, and then lastly is, in the plastic surgeon's armamentarium is actually the use of flaps. I just want to separate the difference between a graft and a flap. A graft is something that you've detached the blood flow to it. So like that skin graft, you've taken it off the body and then you put it down somewhere else, and it has to reestablish that blood flow. Flaps typically, except in specific circumstances that I'll talk about, flaps carry their own blood supply. You have to keep the blood supply attached to it. It has the advantage that it has good perfusion to it, but it has the disadvantages. It's hard to get it from one place to another because you have to leave it attached to its blood supply. And the typical is just what we call a rotation flap. So if you have a big defect here and you have enough tissue on the side of it, you can lift that tissue up and pull it over. And the magic is, well, what happened to the hole that you took it from? For that, you have to do a residency in plastic surgery. That's a secret that we save for the residents to learn. It's not a secret, but it's actually hard to show people without actually doing it. You steal the tissue from the side. So you can't do this in a place where the tissue is very tight. Typically, you do this in the face, the neck, the buttocks, where everyone has extra. So you pull this thing over, and then on the side, then you squeeze together the other tissue on the side. And I will show you an example of that. But it's so hard to actually, even after I've done the surgery on patients, they can look at it, they say, wow, how did you do that? Well, you had extra tissue. Well, where did the extra tissue come from? I said, well, everyone's, I don't want to say you're fat, but everyone has a little extra tissue on the side that you can steal from. I'm going to just sort of skip ahead to this. And here again is another patient with a skin cancer who had to have it resected. And then actually we put a skin graft down just to let it heal up a little bit. And this is the result of after the skin graft healed. But clearly this is not really that attractive looking on the side of his face. And what we did was did a flap, and what you do is you make a cut down here all the way through to the neck, and you do a reverse facelift. So a facelift is when you pull it backwards, and the reverse is if you take this whole piece of tissue and pull it forward. And if you're clever, you make that cut along a wrinkle line. So this is a wrinkle line that would have otherwise gone through this area of the cheek. And you pull everything up, and you can actually get all of that to close. So this defect can be closed, and the donor site came from the neck. It was the extra skin that was on the neck that was pulled up. So does that give you sort of an idea of sort of stealing from some areas for others? In a facelift, you pull the extra skin and you throw it away. That's what you do for a facelift. For these, you just use that extra skin, you pull it somewhere, and then you don't throw it away. You use that extra skin to fill out what a defect of whatever it is that was open. Then there are these pedicle flaps. The pedicle flaps have a blood supply involved. In other words, the person that taught me plastic surgery here, who was a former, he has passed away, but his claim to fame was I was able to identify parts of the body that had these blood vessels involved, that you could actually move pieces of the body around based upon the blood vessel. And here, you didn't have to take a big wide piece of tissue and worry about how the blood was going to get there. If you knew the anatomy, and his atlas is still being used today, if you knew the anatomy and you knew that this blood vessel supplied this piece of skin overlying the blood vessel, you could take that whole thing and you can move it around based upon that blood vessel. So one way of doing it is keeping the blood vessel attached, but stretching the blood vessel out so you can move it. And this is a standard. This is called a radial forearm flap, because it's based upon the radial artery in the forearm. And a clinical example is a patient here who was in a rollover motor vehicle accident and ended up with a fracture and a wound with exposed hardware and tendons and nerves and everything over the back of the hand. And you can take this piece of skin, base it upon this blood vessel, and you can wrap it around to the other side, and you can fill that defect. The defect that's on the other side can then be covered with a skin graft, and that skin graft will take over that other side. Why you need this thick piece of tissue is because of the exposed bone and tendons on this side that won't heal and won't take a skin graft. Skin grafts don't do very well over hard structures. They do better over muscle, but they can heal over hard structures. It's harder to get them to heal, but the function is much worse. That really thin piece of skin just doesn't stretch and doesn't work very well. Now, taking that same concept, you have a patient with this is I think he had this about 6 months, an ulcer over his calcaneus tendon that just would not heal. And nothing we did could allow this tendon to heal. And over time, eventually this tendon will rupture and they'll end up not being able to walk very well. So it's fairly important to fix these wounds. So again, we take the tissue, again, from this part of the forearm, and for the sake of simplicity, it's just a diagram just showing you, and based upon the artery and the vein. Now, how do you get that from the arm to the leg? One day you can sew the arm to the leg and just have them walk around, and we do that on occasion. But a better method is just to take the artery and the vein and under the microscope sew it to a blood vessel that's in the leg itself. So that's called a free tissue transfer, using the same concept of the pedicle flap, but just giving it a little bit more versatility by allowing you to move it and then reattaching the blood supply to it. And that will heal this area very nicely. It gives a nice padding to the Achilles tendon. And again, the area that's on the forearm where this flap came from, we put a skin graft over it and the skin graft heals. Any questions on that one? No? Okay. And then finally, there's a very old technique. This was popularized, I think, if my history class serves me well, back to the between World War I and II, where a lot of the war veterans had these large defects that required reconstruction. And again, say that you have a defect on your foot. How did you get tissue down to the foot? There's not a lot of extra tissue down there. They would actually sew parts of, say, your chest, piece of tissue on your chest to your arm, allow that blood supply to parasitize, then detach it from the chest, and then sew that down. Now, so the blood supply is now coming from the arm into this piece of tissue, and then sew that piece of tissue now down to the leg, and let that parasitize, and then finally detach that so that you can free the arm. Now, you can imagine, because this took months to do this, it did save the patient's leg from being amputated and well worth it, but it was a very large effort. So you can see that doing the free tissue transfer, where that takes, it feels like an eternity doing the operation, but it's really just 6 or 8 hours, that you do a much better job of doing that with the modern technique than walking these flaps around. And I do have to apologize for this next photo, if anyone wants to avert their eyes. It's a patient that has actually a wound from shooting heroin in the arm. It's to the point where the bone and everything is exposed, and because all the veins are gone, all the blood vessels are gone, we actually are not able to attach any blood vessels to it. So in order to reconstruct that, we actually use one of these techniques of parasitizing tissue from one part of the body to another to get that to heal. Okay, done. You can look now. So yes?
I was going to ask if you used hyperbaric oxygen chambers for wound healing?
Yes, I personally do not. We don't have a hyperbaric chamber here, but one of probably the most famous wound healing person here is Tom Hunt, who well, I'll talk a little bit about him later, but his major contribution to wound healing is the recognition that oxygen is important to healing. But how much oxygen is still debated to this day. How much is actually good, how much is actually bad for oxygen. But we do know that there are situations where the tissue is oxygen poor, that if you can get oxygen to the area, that it will definitely help heal the wound. And so for those cases, hyperbaric oxygen is very important. And so in town here, the main center is at St. Francis. So whenever we have a patient that requires hyperbaric oxygen, we will send them to St. Francis. But it's only in situations where you actually can't restore the oxygen in other methods. For instance, I'll go over, so if you have vascular disease and your blood vessel isn't working to your leg, it's much better to do an operation to get blood to your leg than it is to try to drill the oxygen into the leg through the hyperbaric chamber. And so hyperbarics are reserved for patients who either can't undergo surgery in order to restore blood flow, or have various anatomic reasons that can't happen. Yes? Was there a question? No? All right. So the first half of the talk was to sort of go over how wounds heal normally, or how they should heal normally. The second half I want to talk about is what happens when the wounds don't heal normally, when there's problems. And so a couple of definitions. One is complex wounds. Complex wounds we talk about, I've shown pictures of those that are really large, really big, threaten the limb or threaten the life of patients. And then there's a much more subtle distinction between acute wounds and chronic wounds. Some of it is to do with finances. Medicare will pay for treatment of chronic wounds only after a certain period of time. And on a practical level, again, if you just let the wound go by itself, it typically will heal if you have normal wound healing. But once you reach 3 months, the definition, the functional definition, if you have a wound that you've been treating and it's been 3 months and it really hasn't shrunk or hasn't healed, then we term that a chronic wound. And those are patients that really should seek special help. And so the following parts of the talk are, what do we do about those complex and problem wounds?
Question.
Yes?
Have you heard about David Lee, the warrior that's having a lot of problems with his elbow?
The warrior?
The Golden State Warriors.
Oh, the basketball player. Oh, I thought maybe he's...
Do you know anything about that?
No, I don't.
Okay. I don't know very much other than what I read in the paper, but and I think it's a pretty interesting case. He had an injury, I believe maybe 7 to 10 days ago, whereby he hit his elbow in another player's teeth, knocked out some teeth, and so it was taken to the emergency or whatever, and they, well, I guess, cleaned it out and sutured him, and the next day he had this furious infection, so went back in, cleaned it out, and now 7 days later the headlines in the newspaper are that he's back in the hospital again. So is it the saliva, or is it the elbow, or?
Well, actually,
Not knowing very much. What do you?
Oh, no, that's actually a common thing that we deal with. Not so much in the elbow, but fight bites. So we call them, the residents call them fight bites. They are, you get drunk, you get mad, and you punch somebody in the face, but you hit them in the teeth. And it's always it's typically with a closed fist, and the tooth then cuts into the knuckle, and what it does is it cuts deeper than what it looks like. It's just a little puncture, but the tooth has actually entered the joint, or it's entered the joint space. And then the bacteria get inoculated into that area, and because someone is trying to do you a favor and they close the wound, it traps the bacteria inside. and then what happens is that the bacteria multiply within that joint space and then develop an infection. And those are very, very hard to treat. Those, we are constantly on the alert for those. And if you're unlucky or the treatment isn't optimum, you may end up with an amputation. Those are very horrendous problems. The mouth has a lot of bacteria in it to begin with, and then when you inoculate it deep and then you close the skin over it, it just multiplies the problem tenfold. But that comes, I'm glad you asked that question, because we're frequently asked in the emergency room to close a wound, and we have to make a decision. Do you close the wound, get a better healing for all the reasons that I told you about for healing, but accept the risk that it will become infected? So there are a couple of guidelines that we use, and that is how dirty is the wound. So if you punch someone in the mouth, my recommendation is leave the wound open, because what will happen is you will get an infection, but the infection will come out of the wound. It won't go deep. Your body is good at pushing the infection to the surface, and it will come out. If you close it, then you run into trouble. Now, if it's a clean wound and it happens to be on your face, then the balance shifts towards, well, I want a better result cosmetically, and I'm willing to take the risk of the infection. Plus, the face is very good at, for whatever reason, of not becoming infected. We say it's the blood supply or whatever it is, but the face is typically a place that doesn't take an infection, or is able to handle an infection much better. So it depends on the circumstance, depends on the place, and it's a calculated risk that we take closing a wound, whether or not it's going to become infected. Now, the elbow into the teeth, that's probably something that someone else might have said, okay, well, maybe we'll just wash it out, put a bandage on it, do the wound care, and not risk the infection. Certainly when we see that in a closed fist injury after a night of drinking, we always leave those open.
Thank you.
Sure. So complex wounds, chronic wounds. Here's a gentleman who's teaches college in the East Bay, who was in a motor vehicle accident and developed this wound on his forehead, on his scalp, that it was astonishing, but 5 years later, it hadn't healed, and finally someone says, well, maybe you should go see someone about the wound. So we see people, and not street people, not quite intelligent people with good health care and everything, who sort of hope beyond hope that their wound will heal. So 3 months, I think, is a good period of time. If it's not getting better and it's not healing, 3 months, you should probably see someone about that. And then there are really complex chronic wounds, like this patient who had an infection of the nasal oral cavity and ended up having this area completely removed, and actually can be reconstructed. So we can probably, this was about 5 years ago, this patient probably at this point would be a candidate for a face transplant, as opposed to the standard reconstructive surgery. But we were able to sort of get that wound closed and the patient back to a semi-normal life using the reconstructive methods that we have. Just to give you an idea of how common problem wounds are, it's estimated that in the United States, about 6 million people have wounds that would be termed chronic, meaning that they should seek special help. Where I work at San Francisco General Hospital, where I run the wound clinic there, it's the busiest clinic in the hospital. Last year we had over 12,000 visits, and it's really amazing. There's only like 4 nurses that run 4 or 5 nurses that run the clinic, and they see all these patients, that do all the dressings, and they help a lot of people. At UCSF, there were close to 3,000 admissions to the hospital for wound-related problems. And then just looking at St. Mary's Medical Center, which is a much smaller hospital across town where I worked, just in a 6-month period, we just looked at pressure ulcers, just the ulcers that occur when people are laying in bed, bedridden. And so that would be a subset of all these other wounds. There was over 200 admissions for that. So it's a huge problem, I think, that in terms of loss of productivity and expense within the medical system. And then actually I Googled, you can Google, right? So I Googled wound care services in the Bay Area, and I got all these hits. What I didn't realize about Google when I did this is, so I assumed that the wound centers were all these big dots here. And UCSF, I think, is C, and St. Mary's is A or something in there. No, actually, I'm sorry, UCSF isn't in there. UCSF is one of these little dots. The size of the dot isn't dependent upon how busy you are. The size of the dot is whether or not you're willing to pay for it. So the more you give to Google, the bigger your dot is. And so all of these are wound care centers. There's a hotbed of wound care centers in Santa Rosa. I'd be curious to go up there and see what this is. So it's a very large business. Yes?
How do you feel we're doing at our long-term care facilities, especially like later on preventing pressure ulcers?
You know, I think that's where the real, it's not high science, but actually I think that's where the real effort should be made. Because it's much like, you know, cancer or heart disease or whatever, that once you have it, it's a big problem, but it's actually much cheaper and much simpler to just prevent the thing from happening. But we don't make any money from that. So, you know, I'm being a little cynical about it. But the reality is that medicine needs to be pushed towards that type of prevention than it is towards treating whatever it is that has occurred. Now, one good thing, and I'm not going to touch upon this later in the talk, so I'll talk about it here, is a national effort by Medicare and a state effort by the state of California and various other states to identify those preventable wounds and to actually penalize people for, not the people for getting them, but for the caregivers who are responsible for those preventable wounds. And so it has generated a lot of Brownian motion in some ways, but I also have seen the real effects that have focused the attention of healthcare providers to actually prevent it. And hopefully, and this only started a year ago, so hopefully in the next 5 years we'll see a decrease in the number of these preventable injuries. Having said that, I'd say that's only going to help some of it. There's a lot of these wounds occur in the home, in the community, car accidents and those sorts of things that is sort of beyond the scope of medical care. But certainly within a nursing home, we should be able to prevent people from getting a pressure ulcer in this day and age. And I think that things are being done. Awareness is certainly there, and I think ultimately prevention is the key. Which is a good segue to so if you take a look at these wound care centers where they're treating patients, you can divide the patients into three, they're almost split exactly 1/3, 1/3, 1/3. Again, there's a little bit of overlap of the disease process, but 1/3 of the patients are there because they've had some prolonged pressure and they've developed a decubitus or pressure ulcer. 1/3 have vascular disease and develop their problem because they don't have enough blood flow to that part of the body. And 1/3 have diabetes. Now again, as I'll go over with you these examples, they do have interlocking, so diabetics are more prone to vascular disease and pressure plays a role in it. But if you just look at the primary cause of the patient's problems, 1/3 have this problem, 1/3 have vascular disease, and 1/3 have diabetes. So I'm going to spend some time going over what the causes of those problems are and how we go about treating them. So pressure ulcers, they are in predictable places. They are in places that have excess pressure. Now, how does that happen? You sitting here in the audience would never get a pressure ulcer. And why won't you get a pressure ulcer? The reason why you don't get a pressure ulcer is because you don't allow excess pressure to build up over time. Excess pressure is not a lot. We're talking about 20 millimeters of mercury pressure. So if you think about it, your blood pressure is what? 150, 140, if you eat a lot of salt, 160. And your diastolic pressure, the low end of the pressure, is in the 70s or 80s, 60s, 70s or 80s. All you need is about 20 millimeters of mercury pressure, because that's what the capillary pressure is in your soft tissue. So on your arm, on your buttock, on areas, the blood flow going through the little vessels, the capillaries, is about 20 millimeters of mercury pressure. Now, if I put if I take a stick or whatever and just press on that part of your body and I achieve 20 millimeters of mercury pressure, that will stop the blood flow in that area. Now, tissue is very resistant to the lack of blood flow. So I can do that for 5 minutes, 10 minutes, nothing will happen. If I keep doing that, if I do that for half an hour, 45 minutes, you'll start to feel uncomfortable. You'll notice that when you're sitting in a chair, right? You can't not sit still in a chair for, try that sometime. Try to sit absolutely still, even in a padded chair, for half an hour. And your leg will fall asleep, your butt will start to hurt, and you'll shift. So we all do that. We all shift a little bit. And that's relieving that capillary pressure. What we know from a lot of our clinical experience is that 2 hours is about the limit that your tissue can tolerate full ischemia. I can put a tourniquet on your arm, take all the blood away from it, do surgery, and if I let the tourniquet down in under 2 hours, nothing bad will happen to your arm. But if I forget or something happens and I leave that tourniquet on for greater than 2 hours, then bad things will start to happen. The muscle will die, the nerves will start to die, and eventually the skin will start to die. So we know that 2 hours is a critical time limit. It's not exactly 2 hours. Some tissue takes longer than 2 hours, and some tissue is about 2 hours. But if you have altered sensorium, if you cannot feel the pain, you cannot relieve the pressure, then you will lay there or do something for up to 2 hours, and you'll get necrosis of that tissue. Now, that necrosis you don't see it right away. Well, the hallmarks of it is that it takes some time for you to actually notice that it's there. But I want to just go over altered sensorium. So what constitutes altered sensorium? It just means you can't feel it. So what are the patients that can't feel it? So if you're in a coma, right, you can't feel it. If you have diabetes and you're in ketoacidosis and you go into a coma and you're at home and someone didn't come by to check on you and you're laying on the kitchen floor on a hard linoleum floor for a few hours, you'll develop a pressure ulcer. If you are paraplegic, if you have had spina bifida as a child and you don't have any feeling on your buttock and you sit on a hard chair for 2 hours, you'll develop a pressure ulcer. So patients with strokes, patients who are intubated in the intensive care unit, patients who are in the operating room, those are all the patients that end up having these problems. Now again, because we are alerted to this problem in the hospital, we can prevent those. We know the people that have had strokes, we know the people that are in the operating room for long periods of time, and we can try to relieve that problem. But a lot of these patients develop the problem before they get to the hospital. They're all in predictable locations. You can tell exactly how they were laying when it occurred. If it's on the hip, elbow, and the knee, they were laying on their side like this. If they're on the heels and on the tailbone and on the back of the head, then they were laying on their back, and vice, and et cetera, et cetera. They are predictable in terms of the variable tissue injury. Muscle has the highest metabolic rate of tissue, and so it's the first to go. So what will happen is skin actually is very resistant to ischemia. It tends to die later than muscle or fat. And what you typically get is so from the skin on down, you get a little hole in the skin from the death, the fat, and then the muscle, and then finally the bone. And it tends to form this triangle or pyramid where the defect is pretty small from the skin, but once you get down to where the dead tissue is, it's quite large. And so this little hole on the buttock is actually a much larger hole on the inside that is necrotic. And so this is called an ischial decubitus because it's a pressure from the ischium of the pelvis from sitting in a wheelchair for too long. And so this is a patient that was put in a wheelchair and wasn't able to relieve the pressure for long periods of time. Again, this patient here was on the tailbone, on the sacrum, and that's from laying on it that way, and this is from laying on the side. And again, this patient was from laying on the heel for too long of a period of time. Prevention, as your question is, that's the most important thing. For the foot, there are all sorts of mechanical devices to relieve pressure. In patients who are in nursing homes and on bedridden patients, there are special mattresses, there are special beds, there are flotation devices that will relieve the pressure. Now, I have used all those beds, and the vast majority of the beds do not give you complete pressure relief. In other words, there's still a significant amount of nursing care or family care involved in that they will extend the period of time that you can lay there from 2 hours to maybe 3 hours or maybe even 4 hours, but you cannot lay there for 8 hours on any of these special beds, except for one. There's one special bed that you can lay on for long periods of time, but every patient I've ever put in those beds hates those beds. And so unfortunately, it's a great bed, but it's very expensive and patients hate it. And it's a sand bed. It's called a clinitron bed, where there's sand on the bed and then there's air blown through the sand. It's wonderful. I mean, it's like, I love it. You can lay on it and this warm, gentle air blowing underneath, and you feel like you're floating on a cloud. Unfortunately, the patient is literally in, is kind of like a plum in the pudding. They're kind of stuck in this thing, and they can't move very well. They can't actually get up. So they're constantly trying to pick their head up, or they're trying to, because that's what you want to do, and you can't do it in this bed. So I say that the average patient, after a few hours, just says, get me out of this thing. I hate it. But for a patient who's comatose, who's intubated or whatever, they don't really care, and they can be in these beds for quite some time. Now, the intensivists hate these beds because if you need to clear your lungs, one of the things that they do is actually raise the head of the bed so that the head is up and they are better able to clear their lungs, and you can't do that with this bed. Because again, it's a flotation thing, and if you use wedges and stuff to raise the head up, then it defeats the purpose. The pressure gets redistributed. So it's a great bed for preventing ulcers, but it's a terrible bed for actually the use by a lot of the medical needs that it's designed for.
It used to be very common to have the egg crates on, at least when I was hospitalized in the 80s, it's on every bed at Kaiser. And now it seems like those are very hard to come by.
Well,
an expense issue, or did you find that they weren't so useful after all?
Well, actually, egg crates are very cheap. It's the cheapest method of doing it. It unfortunately does not reduce the pressure enough. I mean, every little thing you do is better than nothing, obviously. But it's quite clear that the egg crate mattress, isn't as good when you test the pressure relief than most of the hospital beds that we have now. So if you're at home and you have your whatever bed you have, yes, the egg crate is probably better than that. But for the standard hospital bed that we use now, the egg crate it's actually making it worse rather than better. And certainly for the special beds that we order, they're much, much better than the egg crate mattress. But memory foam? Yeah, so we have that at home. The memory foam is much better than the egg crate mattress. But again, that is still not as good as most of the hospital beds. And again, the emphasis is that none of these products completely replace care. So the care is that the nurse comes into the room and, again, doesn't have to be on the 2-hour mark, but sometime within the night you get flipped over, or you get flipped from one side to the other. And what I find that many families have, the hardest part is, so you're caring for someone at home, and they're going to develop these pressure ulcers, and I mean, someone has to get up in the middle of the night. Even with the special bed, you have to turn them, and so it's either paying for that care or doing it yourself or something, and it's exhausting after a while. So treatment is debridement, prevention, obviously, and debridement. And then in these very deep ulcers where they're over the bone and the bone is infected, then there's healing. Then you have to actually do these flaps. And here, actually, the reason why I put this in is I'm trying to sort of illustrate the extra tissue. So I can take a cut like this, I can swing this piece of tissue over to cover this hole, and then, because there's extra tissue on the side of the butt, I can close that defect on the side. I can just sort of squeeze that extra skin and fat over that area to close that. The next is vascular disease. This is sort of a patient that came in with a wound. We couldn't really exactly figure out, why it wasn't healing. There's a lot of necrotic debris. Someone had tried to clean it up, and 3 or 4 months later, it wasn't really working. And the simple thing would have been just to feel for the pulse. If you feel for the pulse and you don't feel it, unfortunately, this patient, all of this area is very indurated. It's very swollen, and the pulse is not that easy to detect. But there's special instruments you can use, the Dopplers and stuff like that. And there are tests that you do, but the best test is actually to get an arteriogram. An arteriogram is where they inject contrast agent into the artery and then take x-rays, waiting for the contrast agent to go down the artery. And in this patient, this is the lower part of the leg. This is the knee up here, and this is the foot down here. And typically, this vessel, where you see this dark line, should run pretty strongly down. There should be 3 of them running strongly down this leg. And in this patient, you can see where it barely fills it all here. It barely fills it all here. They have one vessel here that looks like it's relatively intact, and then they have this vessel here that has multiple plaques in it, basically atherosclerosis, that doesn't allow the blood vessel to get down. And if you get those blood vessels to work, either by taking a balloon and blowing out the plaque, putting stents in, or actually doing a full bypass, then ultimately it will start to heal. You'll start getting pink granulation tissue, and then that will go on to heal. So the issue about vascular disease is that you really need to get the blood flow down here. Here's a sort of a typical patient who had an ulcer on the heel, and the ulcer wouldn't heal on the heel, and you get an arteriogram, and you see that this is sort of matched to the patient's anatomically. This is up in the thigh, and the vessel is not bad in the thigh, but then once you get down to the knee, the vessel starts to look diseased, and there's one vessel that's going over this part of this part of the leg and supplying the foot. But once you get down to the foot, there should be lots of vessels here, and there's just no vessels there. And again, this is from the patient did have diabetes. This is from high blood pressure, diabetes, and plaque forming in the arteries. So here's his arteriogram showing the blood vessel, the one good blood vessel that he has, going down to the ankle and then stopping around the ankle and then sort of disappearing below the ankle. And the vascular surgeon then took a vein and then hooked it up in the thigh where there was good blood flow, and then hooked it down to this blood vessel down here, giving better blood flow to the foot. Unfortunately, the heel was the area that he was having the problems, and you see that in diabetics they have all these little vessels that are also damaged. Just putting a big pipe to this area doesn't completely solve the problem. You still have to get the blood flow from here over to the heel. And what we did was we took a flap from the forearm, with a long blood vessel in it, and we sort of replumbed everything. So we took this blood vessel that the vascular surgeon had brought to the foot, and then we took our blood vessel and kind of replumbed it down to the other blood vessel that was down here. And then that blood vessel then connected to the native blood vessel that then supplied the rest of the foot. The foot likes to have 2 blood vessels, at least 2 blood vessels supplying it. And what we did was we reestablished the blood flow to the other blood vessel. And that's what the sort of final product looked like, including healing of the heel ulcer. And then the vessel is actually underneath here, kind of replumbing everything. So that is not your typical case. Your typical case is you just do the bypass, and the bypass will bring in enough blood flow to heal it. But for more challenging cases, we have other methods to use. Diabetes, the third disease process that we see a lot of patients in the clinic for, have very typical areas. And these slides I brought from my podiatry colleague who treats a lot of these. The reason why you get these is, again, similar to why you get pressure ulcers in the buttock and stuff. That diabetics will typically, the diabetics that run into trouble with this have a neuropathy. In other words, their long-standing diabetes has damaged the nerves to the foot, and they will have no sensation below the ankle and no sensation below the wrist. It's called stocking glove neuropathy. And so these areas that don't have sensation can't protect themselves. And so as a diabetic, you put on your shoe, and if the shoe it doesn't fit quite right, or you have new shoes, or you get a rock in the shoe. So happens to me all the time. I'm walking along and suddenly, oh, I got a rock on my shoe. You notice it right away, you take your shoe off, dump the rock out, and you go back on your way. Now, if you couldn't feel that rock was in your shoe, and that rock sort of makes its way around, you'll end up with an ulcer wherever that rock happens to land. And more so than that, as you develop these neuropathies, your foot the bones of your feet start to get distorted, and they get to points where they start to create pressures. And so deformity, limited joint mobility, and ultimately the common denominator is excess pressure in these areas. Then on top of it, diabetes causes a problem with healing. Diabetics typically can't heal things as well as other people. And so this is a sort of one after another phenomenon where they end up with a very high rate of amputation. And so this is a quote that pain is the gift that no one wants. However, and I'm hoping to convince you that pain is necessary, that pain is protective, and the lack of pain is actually what gets you into trouble. Deformities of the toes and feet that end up with, so if you think about it, what's the likelihood you can put that foot into a regular shoe and not have some area that has abnormal pressure to it? Very little. I mean, there's some shoes that I see that normal feet can't fit into, but with a toe overlap like that, it's very hard to get into a regular shoe that doesn't cause excess pressure. Bunions, claw toes, and I'll go over what a Charcot deformity is, just as an example. So all of these overlapping digits, rocker bottom feet where the toes are like this, and those are all excess pressure points that cause problems. And here's a diagram of, so if your foot is in the shoe and your bones are twisted like this, that you're going to end up with excess pressure on the top of the toe and excess pressure on the bottom of the foot. And those are typically where we see those ulcers occur. And again, it doesn't have to be high pressure. It's just very low pressure, but constant low pressure that will cause the problem. And the statistic that is most revealing is that diabetics, so if you look at all amputations of the legs in the country, 50% are related to diabetes. And 85% of all of those amputations are preceded by an ulcer. So you get the ulcer doesn't heal, you get an infection, and then ultimately you come to an amputation. So it's not a trivial problem, these ulcers, and it's actually a very big challenge to treat these. Again, offloading. Prevention is the best method. If you identify, so that's why I think all diabetics who have longstanding diabetes, who have clear sensation problems with the feet, even with normal appearing feet, really should see somebody about proper footwear, because I think that's where the biggest effect is prevention. A Charcot foot is, if you look here, the bones of the ankle and the foot have altered themselves to the point where this bone is actually just sticking out into the bottom of the foot. And if you walk on this, just imagine what happens to that. You end up with drilling a hole out the bottom of the foot. So the treatment is actually that you actually have to put that bone back in place or shave that whole bone off and then heal the wound that way. So what I term surgical offloading. So you surgically reduce that area that will cause the problem. So any questions on that? That sort of finishes my my presentation of the clinical aspects of it, and then for the last 10-15 minutes I'll cover some basic science issues. Yes.
So you're going to get to the stem cells?
Oh yes, actually, saving the best for last. In this, yes.
Since you talked about diabetes so much, what is it about that disease that causes this kind of neuropathy?
Why it causes the neuropathy. Now, in diabetes, it's clear that it's a major actor in the pathology of diabetes is actually the high blood sugar. I know that seems silly because what is diabetes? It's high blood sugar, but you can create artificial situations where animals or whatever aren't actually diabetic, but you just raise, so in a dish you can raise just the glucose level, and you'll see a lot of these effects. And what it does is the byproducts of the glucose will actually damage cells. So in wound healing, it damages those cells that I talked about that actually are responsible for healing. And then for the nerve, this is a leap of faith on my part because I don't follow this research on a minute level. But it's obvious that the glucose, the high glucose, is toxic to the neurons that are there. So those cells become damaged. Now what is always unknown to me, and I think to physicians in general, is why is it in that distribution? In other words, why aren't other nerves damaged? They are damaged, but not nearly as much as in the foot and in the hand. And so that I don't have an answer to. Why are those nerves more sensitive to that high glucose than the nerve to your buttock or the nerve to your shoulder or the nerve to your neck? But that's a great segue because I want to talk about the science of wound healing, and the best model that we have is actually diabetes. So Thomas Hunt, a mentor of mine, is probably, again, the best known scientist at UCSF who pioneered much of what we know about wound healing. What I say is actually, if you look at all of the science of wound healing for the last 30 years, his name will somehow be linked to it. And even though he's been retired now for 7 or 8 years, he still will be on the most major publications that are coming out. So I would like to just use as examples, again, wound healing research, the basic science of wound healing research covers many monthly journals. But what I just wanted to do is pick 3 examples of the current topics of wound healing in basic science. And the first is PDGF. That's actually sort of an old story. That's about 15 years, 20 years old. That's a protein that we know will accelerate wound healing. This is my own research, so I know this pretty well. Hypoxia-inducible factor is a transcription factor. That's a protein that will activate genes within the cell, and that is known to affect wound healing. And then this is more of a lark. It's and I'll sort of, if I don't have enough time, I'll sort of bypass that. This is what I thought to be a gimmick originally. This is a product that was marketed for healing wounds, and it's basically just a vacuum. It just sucks the wound, and it's called negative pressure wound therapy, or commonly termed the wound vac. And so if you go to the hospital or you go to wound care treatment centers, you'll find that the wound, and that's what I'm paid for as a consultant, is to consult on this wound vac. That this negative pressure therapy is somehow magical in in healing wounds. It's not magical, but there are some explanations of why it does have some effect. PDGF, this is a diagram I showed you. So platelets are very important. They form the clot. And early on, they were able to, Dr. Hunt and others were able to look at the proteins that were in the platelets. And one of the factors they found was called platelet-derived growth factor. And there are actually, if you look through the literature and look in the wound, there are literally dozens and dozens of these proteins. But the most abundant is platelet-derived growth factor because there's a lot of platelets, and the platelets are full of this factor. So they took this factor and they isolated it, they purified it, and then they did animal studies to look at whether or not it accelerated wound healing. And they used the diabetic model because, like I said, if you just took a regular animal, the wounds heal no matter what you do. But if you take a diabetic animal, the wound will not heal as it usually does. But if you put PDGF back into the wound, it will heal the wound, not back to normal, but much faster. And so what Johnson & Johnson did was take that protein, isolate it, make a recombinant protein, and then apply to the FDA for treatment of diabetic foot ulcers. The reason why I use PDGF is because it is, even after all these years of drug discovery, it is still the only product that has been shown to accelerate wound healing. It doesn't mean the other products don't work, it's just that no one's bothered to test them. But Johnson & Johnson plunked down X number of millions and hundreds of millions of dollars, did the trial, and showed that in diabetic foot ulcers that PDGF will heal the wound faster. The FDA approved it about 15 years ago, and it accelerates the wound healing by about 15%. So the question is, well, 15%, is that, well, it's better than nothing, but is 15% enough? And nobody actually knows. Nobody's actually ever looked to see whether or not the amputation rate goes down. Or if they have looked, they haven't found anything, and they haven't reported it. So it costs about $1,000 for a 1 to 2 week therapy. It does heal the wound faster, but does it end up actually saving the limb, which is what, that's the reason why you would want to heal the wound. Nobody actually knows. And then what about all those other proteins? Those other dozens of proteins that are in the wound that nobody has put the money down to test those proteins. Now in animals we've done it, and we've all shown that those heal the wounds faster, but nobody has put the money down to do it in human trials. And the reason why is because the wound is very complicated. There are lots and lots of proteins. And in diabetes, all these proteins are diminished. If you take a diabetic patient and you sample the wound, you'll find that all those proteins are diminished, and for various reasons related to having the glucose be too high. So my laboratory, in sort of taking the next step, said, well, how do you control all those proteins? Is there a method whereby you can sort of shotgun it and make all those proteins go up? And maybe that's a better method to use to treat this than individual proteins that could be done. Now, that wasn't my idea. That's an idea that's been very current for all types of research. So first, we proved that it was important that this transcription factor called HIF, it's called hypoxia-inducible factor. It was first found in models where there wasn't enough oxygen. So if you don't have enough oxygen in some tissue, your tissue will be stimulated to make hypoxia-inducible factor. And one of the first things that hypoxia-inducible factor was found to do is it goes to the cell and makes erythropoietin. So you think, wow, erythropoietin, why? So erythropoietin is that which stimulates your body to make more red blood cells. So that makes sense, actually, if you think about it. The body senses it is not getting enough oxygen, so it forces the bone marrow to make more red blood cells that then will carry more oxygen to the body. So it fits. And what they discovered was this transcription factor actually has multiple actions on multiple proteins that all increase oxygen within the tissue. And so we thought, well, that should be important in wound healing, obviously. We looked and saw that it was decreased in diabetes, like many other proteins, and that we showed that if you manipulate that protein, if you're able to increase that protein, that you'll actually get improved healing. So in a diet, so this is a fat mouse that's diabetic. If you look at it, the protein is diminished. I won't go through all the little details. I'll just get to the punchline, which is if you actually raise the HIF level, if you put a transgene down onto the wound such that you raise the protein of the HIF, this is a mouse that heals normally. So this is, a wound is 100% at the beginning, and then over time, a normal mouse will heal that wound in 20 to 25 days. Here's a mouse that's diabetic. It will take up to 45 days to heal that wound. And if you apply this transgene, it will heal in about half that time. HIF is also activated by chemicals. So you don't have to put the gene down, you can actually put chemicals down. Cobalt chloride will cause HIF to go up. It's not specific, it causes a lot of other things to go up, but it's a chemical that will cause HIF to go up. And it too will cause the wound to heal faster. And then, so that was my work here. And then at Stanford, a similar study actually using desferoxamine, which is an iron chelator, will be put into the wound. It will actually cause the wound to heal faster, and it will make HIF go up. And then since those studies, I've read at least 2 or 3 other studies that have shown that other chemicals that can be used to stimulate HIF will also improve wound healing. So the next step is obviously to take some of these chemicals, put them into human wounds, and see if those will heal. And so that's the next step on this project in terms of trying to prove that A, it is important, and B, that it can overcome some of these problems. Now, to the stem cells. So what do I think, or what do the people who are doing this research actually think is actually causing the improved in wound healing? So if you take a mouse, a normal mouse or a diabetic mouse, and you irradiate it, it will knock out all the bone marrow in the mouse. If you take a sister or a brother mouse, identical to that mouse, except it's green. So we have these green mice. I don't know if other lecturers have talked about it, but they glow green. And you take the bone marrow from that mouse and you transplant it to this radiated mouse. The bone marrow now in that mouse will become green. So, but that's the only cells. So it's like a bone marrow transplant amongst humans. If you have a bone marrow disease, you can get irradiated, kill that bone marrow, and then you get a donation of bone marrow. It'll repopulate your bone marrow. And then if you create a wound over that, and then you look in the wound, this is the diabetic mouse without the HIF treatment. This is the diabetic mouse that's been treated with HIF. So what it's done is it's actually elicited a lot of cells directly from the bone marrow into the wound. And some of these are just inflammatory cells. They're white blood cells that have gotten there. They're sort of fractions of platelets and things. But the large majority of these cells are actually termed stem cells. In other words, not the embryonic stem cells, not the cells that will make whole organisms and stuff, but the stem cells that are within the bone marrow that are constantly perpetuating the bone marrow. And these cells, for a lot of other studies, have shown that these cells are critical in the healing of the wound. We used to think 20 years ago that the cells in the wound did most of the healing. The fibroblasts there, they just, like I said, I showed you those cells getting proliferated. But what we understand now is that it's the cells that are actually coming from elsewhere into the wound that are critical. If you stop that process, if you slow that process down, then this whole process comes to a grinding halt. The cells within the wound itself are unable to, by themselves, heal the wound. It's those cells coming from elsewhere. I'm getting close to the end of the time, so I'm just going to jump ahead and just give you the punchline to the negative pressure. So the negative pressure dressing, which are these wound vacs, basically they're on a big vacuum pump and they sort of suck the things out. So I'm just going to skip ahead to what happens is, so they're sucking all this stuff in, and they create a hypoxic gradient within the wound. So actually so there's a lot of malarkey in these studies, but some of the studies that actually make sense to me is that they actually showed that if you measure the oxygen within these wounds, there are these areas, because of the pressure, that actually have decreased that oxygen and that hypoxia. And then you develop an oxygen gradient, and then what happens is that the cells then get attracted. So I just use my own my own slide for this, but because the data hasn't been published yet, so I don't have the publication to show you. But a group in Boston has shown that if you take a mouse and you put one of these vacuum things, the hard part is getting the little vacuum thing onto the mouse. But if you put these little vacuum things onto the mouse and you do the model that I showed you with the bone marrow transplant, that the same thing happens here. That the vacuum brings out those cells from the bone marrow, where if you don't have the vacuum, those cells remain in the bone marrow. They don't come out. So, so I think that there is some science involved in how that mechanism, that suction device is actually healing the wounds. However, I wanted to just tell you that most of it, though, is a marketing hype. Because if you look at, so CMS is the Medicare auditing branch. If you look at, so the company who makes the big company that sort of originated the product, last year had an annual sales in the United States of $1.2 billion. Worldwide sale of, I think, $1.8 billion. And so obviously this is a big expenditure on Medicare's part to pay for this. So they went and audited the company and said, well, you know, you're using this product on a lot of our patients. They found that 19% of the patients had the product used for over a year. So it's astonishing. I mean, if you put something on a patient's wound for a year and the wound isn't closed, something must be wrong. So this is sort of a big alert that maybe you might be overusing the device. And then if you actually look at the company says, well, the product should only be used in these situations. And they have a kind of a big laundry list of the situation. That 23% of the patients that had the product being used actually had improper use. In other words, they didn't meet any of the criteria for the use of the product. So it's clear that the product does have some utility. I think there's some science involved, and clearly the clinicians wouldn't be using it if there wasn't anything that they thought was working. But it's clearly being overused to, I'd say, the detriment of society. That it's a huge cost of doing this, and many of these patients are clearly not benefiting from that.
Is the improper use for lack of training of the technicians, or?
I don't know for certain. This was just a report from the medic. So there's not the detail of it. But what's astounding to me is I don't think it's from the lack of training. It's from just looking at the patient's chart and saying, okay, does this patient meet any of the criteria that the company has set out for the use of the product? And so the interpretation is, yes, whoever is putting that product on either isn't reading the instructions, or they might be induced to put the product on even despite the fact.
Or the company wasn't disclosing or didn't know the time period that it should be used, really?
Oh, no, I don't think so. I think there's a profit motive involved in the use of the product, and I think even the company would admit it. Yes?
Do you expect to heal the wound by negative pressure?
By the negative pressure? There's no set criteria, except I'm saying common sense. If I treat a patient for a year with something and it hasn't healed, I would try something else. But like I said, I showed you examples of people who were 2, 3, 4 years out with a wound, and they never sought help, or their doctor never thought, oh, maybe you should go see someone to have this fixed. So I can't answer for you exactly the time period, other than to say that for most, the definition of a chronic wound, one that isn't healed properly, is 3 months. So if you have a wound that's greater than 3 months and it's not going anywhere, something should be done. Now, if you do all those things and it still doesn't heal, all right, fine. Then that's it. Maybe you need an amputation, maybe whatever. But what I'm talking about is just patients who are getting very standard dressings, not using anything remotely modern, and going on for years without getting better. So with that, a little paid political advertisement, I get to do that, is our practice, the UCSF practice, is actually at St. Mary's. mostly because of room, space constraints. There's just not a place to put it on this campus. And St. Mary's has been very, very generous in allowing us to rent the space and provide the help. And they also get, income from doing so. But so we're based at the San Francisco Wound Care and Reconstructive Surgery Center. It's half UCSF physicians, half physicians who are in private practice in the local community. We have a multidisciplinary approach. It's not just a plastic surgeon or it's not a vascular surgeon, it's everybody. There's infectious disease experts, there's internists, there's diabetic people, there are rehab specialists, nutrition specialists, but it's surgery centered. In other words, we feel as if the most effective way of treating a wound is try these products, try whatever, and if they work or the patient's too sick to have surgery, then we just stick with that. But if the goal is to get the patient back on their feet or back to productive life as quickly as possible, we'll be more inclined to actually do surgery rather than the wound care itself. And see, they're very they love to do these ads. We love my kids get a real kick out of seeing these ads and stuff. And then just a thank you for being here.
Can I see the slide before that you just passed about nutrition?
Actually, this is if you want, I can go into this. The finishing thing is that there are a few things that we know will absolutely help healing, and we call it the Hunt protocol. So he defined these things through basic science that that have proven over time to actually help healing. And that is clearly, if you're malnourished, you're not going to heal. So there are criteria. I didn't put all the criteria here, but you should have a nutritional evaluation to make sure your protein and your albumin and all that sort of stuff levels are adequate. These vitamins, by and large, so there's a caveat here in that not excessive levels of these vitamins, but lack of these vitamins are clearly instrumental in poor wound healing. Vitamin C is controversial. Certainly you don't want scurvy, but there is some evidence that, higher than levels of vitamin C will help. So it's not just so low that you get scurvy, but higher levels will help. Vitamin A is helpful if you're taking steroids. So steroids will decrease wound healing for a variety of reasons, and vitamin A will counteract that. But if you're not on steroids, high levels of vitamin A haven't really been shown to help in wound healing. So all of these have some sort of caveat to them. But we try to maximize these as much as possible for patients to promote wound healing. Any questions about any? Because many people have specific questions about their favorite wound healing product, vitamin or grandmother remedy. Yes?
Sort of a technical question about your stem cell research. In a non-diabetic mouse, does wound healing get the same effect?
No. So if you look at as I said, all of this is in comparison to the normal mouse. That the normal mouse will heal very quickly. There'll be a blast of stem cells in the normal mouse. What's sort of challenging, or what some people did, was actually take a normal mouse and just give it a lot of glucose and see what happens. And actually that decreases the number of cells that come out. So it's clearly related to that glucose level.
But you're still getting stem cell derived cells
in non-diabetic mice.
In non-diabetic.
Yes, absolutely. Absolutely. That's the normal process. So it's only in that artificial process of diabetes that we see a diminished stem cell load, and then we actually can show that if you correct that, it corrects the healing.
And then when you're giving them your hit factor, or is the amount of stem cells comparable, or is it different?
It's still different. It's still not normal levels, and you'll see the healing curves are not normal. They're shifted towards normal, but they're not nearly normal. Which is to say, there are other factors that are involved that we haven't found yet.
This peripheral neuropathy sometimes has been associated with alcoholic pain. And I'm just thinking beyond the diabetic. I'm wondering if this means there's a different causality.
I think the final causality is the same. Lack of sensation leading to excess pressure and then necrosis. But whether or not the neuropathy is due to the same mechanism, I don't know. Thank you very much.